So, very good evening to everyone. On behalf of IAPEN Kolkata chapter and community core group IAPEN India, I am Soumyendu Ghosh. Welcomes you all to this platform of learning. So today's topics are chosen. It is very intricately chosen, and I always want to thank our national president Shiv Shankar sir, who has given us this opportunity, along with our EC members, Shangamitra ma'am, our Kolkata chapter, Ranu ma'am from the community core group, and all our seniors, those who have given us this opportunity for today's topic, selection of this topic. This is a very common topic. Everybody will say what we will learn about anemia. Anemia is a very common topic. But still, I will say we will learn very differently from Ms. Vijaya on anemia and Mr. Soumam from NIN about the vitamin D. So at the end, we will take some questions. On request of Shiv Shankar sir, I will just share few slides on the anemia screening. I request everybody to keep on mute, those who are outside especially. So basically, anemia is very much alarming in India. Anemia is a significant public health challenge in India. And iron deficiency anemia result in impaired in the cognitive development and motor development, especially for the school children, and decrease work capacity, especially in the urban populations. In the mains also, we are finding anemia. The effects are more severe in the infancy and early childhood. In pregnancy, iron deficiency anemia can lead to many complicated problem, that is even the prenatal loss, prematurity, low birth weight babies. So the National Health Mission under the Ministry of Health and Family Welfare, Government of India has launched a program in 2018, which is called Anemia Mukt Bharat, that is Anemia Free India. So Anemia Free India has many strategies. There are 6 important strategies that I will discuss today about the Anemia Mukt Bharat. So first, let me share my screen. Once the screen is shared, just let me know if it is shared or not. Can you see my screen now?
Yes, sir. Yes, sir.
Okay, thank you so much. So let me make it a full screen first. Okay. So the part which I will discuss is very important thing, that is the screening and the early diagnosis. It is very, very important thing. So the National Anemia Day in India, it is observed is 21st March. In 2024, it has been observed, but internationally, the anemia awareness is observed in 13th of February. So it is very important. The strategies are given in the right side of this. You can see of the screen. So I will discuss the strategies also, because anemia affecting around more than 1.9 billion people worldwide. 90% of the cases are in the countries like us, like Bangladesh, Sri Lanka, India, and African and Asian accounts for 85% of the anemia cases. So you can consider anemia as a global burden. WHO has said about the anemia as a global burden. So if you see the anemia prevalences in under 5, in the states, it is given accordingly. So Assam being the highest, even in the age group of 15 to 49 years in women and 15 to 49 years in men also. So males are also not lacking behind in the prevalence of anemia. So it is very, very important awareness and education. It is the request to all the consultant dietitians, especially who are doing the community practices and those who are doing their OPDs and the pediatric dietitians, those who are working. I request everyone to please keep on mute, and thank you so much. So whatever the things are coming, so this is very important to keep attract, and early diagnosis is very important. So during our regular health checkup, we will always request our patients go for the hemoglobin checkup. Even the people who are doing their eating a non-vegetarian foods, even we can find in the urban populations, vitamin B12 are also very, very low. So that will be discussed by our next speaker, that what is the things having. In the childhood, adolescence, pregnancy, and the adult, after the launch of this anemia, that is Anemia Mukt Bharat, though it has improved, the status has improved, but for the children and the adolescents, it has not yet so much improved. So there are many strategies the government has implemented to eradicate anemia. So 6 out of 10 children in India are suffering from anemia. And one of the most important program, those who are working for the pediatric populations. So pediatric nutritionist, I will request that you will just tell the parents about the anemia, about the awareness of the anemia, because low in iron means cognitive development will be poor, and you will aware. Everybody please mute yourself, everybody joining please mute yourself, and I request I request the co-host to mute everyone because it is disturbing the session. So whenever you are joining there you can mute yourself. So 6 out of 10 children in the India are suffering from the anemia, and deworming session is very, very important. So it is our responsibility as a dietitians to tell our parents about the deworming and to alert the pediatrician. Even the teens, especially in the girl child, in the start of the menarche or the menstrual cycle, there is a rapid growth spurt also. And teens are more prone to iron deficiency. What is manemia? That is, males are also not exceptions. 1 in 4 men suffers from iron deficiency anemia. And if you come across the data, it is also very alarming. Even in the urban populations, men are suffering. Even in the geriatric populations, the peoples are suffering so much with anemia. And even the cardiovascular risks are increasing when there is anemia. Even anemia, that is renal impairment, CKD patients are mostly suffering from anemia. All of you know it is impairing our quality of life, and due to demineralizations, there is a high chance of fracture in the geriatric patient. These are the different age group and the criteria or the diagnosis of the hemoglobin level. So when the children is 6 months to 5 years of age, the mild is 10 to 10.9, the moderate is 7 to 9, and below 7 is severe hemoglobin when blood is required, when need for the blood transfusions. So if you see in the right side, for the pregnant woman, the criteria, the WHO criteria is 11 gram per dl. For non-pregnant, if it is below 12, the lady will be regarded as anemic. And for the men, if it is below 13, the man will be regarded as anemic. Because somebody is thinking that मेरा तो 10 के नीचे नहीं हुआ तो मुझे अभी सप्लीमेंट का जरूरत नहीं है, मेरा तो 13 है, मेरा तो 12 है, I am very happy with my hemoglobin. No, the criteria for the pregnant woman is 11 gram per dl, the non-pregnant 12 gram per dl, and the men, it should be above 13 gram per dl. So anemia causes in India is faulty infant and young child feeding practice, because the children nowadays, those who are doing your pediatric practices with the pediatrician, you know, the children are very much fussy eater. The children do not like to take enough proteins, which are iron-rich food items. They do not like to have good amount of fruits, vegetables, green leafy vegetables. So there is always a deficiency of iron and iron deficiency anemia. So it is necessary to educate the parents first about the balanced diet. Dietary insufficiency in anemia, presence of iron absorption inhibitors that our next speaker will describe, many infection like malaria, hookworm infestation, poor iron stores, that will be also discussed by my next speaker. Ms. Vijaya will discuss what is iron overload, what is iron stores during the infancy and childhoods, and different hemoglobinopathies, that is thalassemia and sickle cell anemia. You know that people will have suffering. So according to the Anemia Mukt Bharat, The government, central government has 6 beneficiaries. Who are the beneficiaries? The women in the reproductive age, the children in age group of 5 to 9 years, 10 to 19 years, pregnant women, lactating mothers. Anemia Mukt Bharat is significantly public health challenge in India. Iron deficiency anemia result in impaired cognitive and motor development in the children and decreased work capacity in the adult. So the effects are more severe in infancy and early childhood. So if we have to treat the mother who are pregnant, and pre-pregnancy counseling is very, very important for iron, folic acid, and vitamin B12. During pregnancy, early childhood, when the children start weaning, because breastfeeding, breast milk is low in iron, you all know. Even there is a tendency in India to give too much of cow milk. Too much of cow milk, 1 liter per day to a 1-year child will lead to anemia. It is very common. So who are the beneficiaries? Children of 6 to 59 months, that is less than 5 years, 5 to 9, adolescents 10 to 19, pregnancy lactating, and women in the reproductive age. They are the beneficiaries of Anemia Mukt Bharat. These are the strategies: prophylactic iron folic acid supplementation, intensified year-round behavior changes, communication, mandatory provision of iron and folic acid fortified food in the public health programs and schools. Periodic deworming, very, very, very important for the children, adolescents, and pregnant mother. Testing of anemia using digital methods, the point of care and treatment, and addressing non-nutritional causes in the anemia. So these are the very important 6 intervention. So the target groups I have already discussed, and we are also under the guidance of Shiv Shankar sir. We are working for 2 to 6 year children in the school age schools. We are working for the anemia, and prophylactic iron folic acid supplementation is very, very important. So these things will be described by our next speaker. So I'm not going into details. So don't ask only for hemoglobin test. With the only hemoglobin test report, you cannot say a person is anemic or not. So CBC is very important. Ferritin test, iron profile test, vitamin B12, serum iron, iron binding capacity, hemoglobin erythropoiesis, reticulocyte test, and folate test. These are the 7-8 tests which are very, very important for a person to be done if you want to know the person is anemic or not. And as I am working with the psychiatrist, so we see the anemia deficiency and the vitamin deficiency lead to low cognitive developments. So when the psychometric tests are done and when we treat with them the vitamin D or that is iron, so we can get a very good result in the cognitive health. So blood tests, these are the blood tests which I have already said and ma'am will discuss. I will just, this is my last slide, digital hemoglobinometer, which we are now using for, which doesn't require any blood, it is like measuring the partial pressure of the oxygen. So it is the point of care. And if you see, it is non-invasive screening digital hemoglobinometer, which you can keep in your chamber like a hand grip meter or like a BP machine. You can keep in your chamber. And community health workers can also use this digital hemoglobinometer because it doesn't require a drop of blood to check hemoglobin. So these are the programs which are done all over India. These are the few programs of north and eastern part which we did. So this right side you can see this is the digital hemoglobinometer where this is connected in your finger and the readings are coming within 10 to 15 seconds. So this is a very good device to detect hemoglobin, and along with a balanced diet we educate the mother, and this is working in a very nice way. So these are the public health implications of anemia: reduced physical development, impact pregnancy outcome, cognitive development, and obviously it is a global burden, so economic impact is more. So it is very, very important for our part, for a dietitian's part, to educate the community. These are the programs. we have done mostly in the schools and colleges. Schools should be ideally chosen. I request all the dietitians who are working clinically or in the community level, please do some campaign in your locality, start from your locality. And if you can educate at least 10, 15 people in a month also, you will be satisfied, because that 10, 15 people will educate hundreds of people. So these are the few pictures of school camps. These are the few pictures of community camps where in the right side picture, you can see we need to involve the audience. Without involving, it should not be a one-side talk. You need to involve the audience. So without any delay, we will go for our main topic today. So if we need anemia-free India, we first need somebody who can create awareness in the society through social media, through campaigns, through YouTube, through Facebook. You need to do more and more programs. So now I am coming to our first speaker of this session, who will be discussing about anemia, and in a totally different way that we never know. Many of us as a practicing dietitians, we do not know what is these things. So how to implementation is very, very important. Unable to do it full screen, Vijaya. That's it. Sorry. So Ms. Vijaya is the founder of Biotem. She is actually the faculty of biochemistry. She has done triple MSc in biotechnology, biochemistry, and also in nutrition. So she is also the regular faculty in cognized nutrition. She has many chapters in books. She is being speaker in many scientific sessions. She has completed her triple L certifications from IAPEN, and she is having more than 15 years of experience in the field. She is teaching the medical or the MBBS students in the field. She has a vast knowledge in sports nutrition, biochemistry, molecular biology, and nutrition. So without any delay, I would invite our first speaker, Ms. Vijaya Das. We are eagerly waiting to listen from you. Thank you. Ms. Vijaya, over to you.
Thank you so much, Mr. Soumyendu, for such wonderful introduction, and a very good evening to everybody present. I'm very grateful to IAPEN Kolkata for giving me this opportunity. And I'm also delighted that today we will be discussing a very important topic, which is very rarely discussed. So today we will be looking into the facts which we need to know while we are dealing with somebody who is anemic. Right? So what happens is that we typically always restrict ourselves to the values of hemoglobin, but there is a lot more to know. If we have a clear analysis, then we can surely help the patients in a better way. So while talking about anemia, obviously the very first thing in mind that comes is iron. So iron is definitely a very important element, not for today, since ages, right? And even the core of the earth is made up of iron. And maybe that is the reason that a very little amount of iron is only available on the surface of earth. So we humans who are actually requiring this iron many a times are in trouble to extract that iron, which is very minorly available in our environment. So a human body typically carries 2 to 5 grams of iron in total, out of which the major portion is for, of course, RBC production. Other than that, iron is also used by myoglobin, which is a part of our muscle, which gives energy to our muscle, oxygen to our muscle, and our body has a storage for iron. So definitely iron is precious. And we all know that the major source of iron for our body is the diet. Now, the food that we eat, it surely contains iron, but then also we are very prone to iron deficiencies. The reason is that the iron absorption rate is very less. So only about 10% of iron typically get absorbed. And we all know that any nutrient which you are taking, it generally get assimilated, or it generally get absorbed by the small intestine, right? But in case of iron, the absorption and the decision of how much amount of iron will be absorbed will be made by the intestinal cell, by the intestinal mucosal cell. And that is how the iron absorption process becomes very different from any other mineral that we know. The mucosal cells of our intestine not only decide that how much iron we will be getting from food, rather it also decide that how much amount of iron we will be excreting. So I believe many of us must have experienced this, that intake of so much of iron supplementation many a time leads to constipation, right? A severe constipation maybe. So the reason is that the excretion, the movement of iron in our body is very slow. So when we are overburdening ourselves, the constipation-like situation may surely arise. So as of now, we understand that this mechanism of iron absorption, utilization is totally different. So iron actually follows a homeostasis. So our body has a mechanism to check that how much amount of iron we have at this moment. And depending on that, the body decides that furthermore, how much amount of iron we will be absorbing. So like say, for example, there is somebody who is anemic, right? Or who is having severe iron deficiency. So the iron absorption for that person will be more than a normal individual. If there is somebody who is having iron overload, then the iron absorption for that person will be less. And this is governed by the intestinal cells. So what happens is that these intestinal cells, they have certain ferroproteins, certain chambers, which decide how much amount to take. So if somebody is iron deficit, there will be more ferroprotein and more absorption. If somebody is having excess iron, like somebody is taking iron supplementation randomly, so there will be excess free iron in the body. So these ferroproteins in the intestine will be reduced, and the absorption of iron will also be reduced. Now, in this context, I have a question to raise here. And that is that, which means that for our body, this mucosal cells are very important in order to make sure that we get the right amount of iron. So this mucosal cells, if they are so much capable of deciding that what exactly should be the iron status of our body, then what will happen to those who are suffering with Crohn's? So like we are totally aware that in case of Crohn's, these mucosal myelin, these mucosal cells, they are inflamed. There is chronic inflammation going on. And as a result, for these patients, iron absorption becomes very, very challenging. While talking about iron absorption, we surely should not forget the acid, the HCl acid that we have in our gastric chamber. Now, these acids are very important, and we all know that the acid is going to help in iron absorption. Now, the problem begins when we are dealing with somebody who is having acidity issues. Like, say, for example, there is someone who is having chronic acid reflux, right? So mostly what happens that they are prescribed with drugs like PPI, proton pump inhibitor. The most common categories of drug are suggested. And these drugs, they stop the HCl. They block or they reduce the HCl level excessively in the stomach. So what happens is that when there is a continuous exposure, when there is a continuous intake of proton pump inhibitor drugs, then the iron absorption will be lowered in long run. Now, there are so many such drugs like we are aware of. One of which will be the pantoprazole, the very commonly known, our very own and known Pan-D, that we generally see people taking randomly, right? So what happens is that this type of PPI in a continuation can also be a reason behind iron decrease. There is a condition which is also called as parasite-causing anemia, which Mr. Soumyendu has already elaborated that parasites can also lead to anemia, particularly if I talk about intestinal parasite. So what happens is that mostly whenever a parasite grows, it demands iron for their growth and proliferation. So whenever we are infected with a parasite, like say, for example, intestinal worms, we are infected with intestinal worms, right? So there will be excessive utilization of iron, and at that point, there will be a severe chance of anemia. So in this situation, there is poor nutrition, there is poor absorption, and ultimately that can lead to iron deficiency. Now, at times, it becomes very difficult to analyze that how do we confirm that, yes, this is a parasite causing anemia. So what can we do? So one very simple way of analyzing that whether somebody is having a parasite causing anemia is to check the values of eosinophil. Now, eosinophils, like we know, it is a part of our CBC blood count. WBC category contains the eosinophil values. So whenever there is a parasitic infection and there is anemia as well, so we must check the eosinophil values. If the eosinophils are higher, then it is an indication that the person may be suffering with parasitic anemia. Now, before I proceed further, I just want to share this wonderful quote with you all. And it says that your blood tells the whole story long before the symptoms appear. And I believe it is so true that if we have a clear understanding of the blood reports, then actually we can keep ourselves far ahead of the diseases. So in terms of anemia, the most common blood report that is typically used is CBC, complete blood count. And that is used because we have this value called hemoglobin, and that is a sheer indication of anemia. Now here, as because today's topic is beyond hemoglobin, so we will see that other than hemoglobin, what else do we have in this report which can help us to understand the type of anemia. So in a CBC blood report, there are basically three sections. So like there is TC, which is the total count. So we can see that how much RBC or WBCs are there. There is a differential count, that is the levels of neutrophils or eosinophil. So that tells us about the immune system. And there is RBC indices. So RBC indices, which are also called as blood indices, are very important in terms of anemia management. So these RBC indices, they show certain values like MCV, reticulocyte percentage, MCH, and RDW. And these values, they have so much information in them that if we can decode them, we can actually understand the reason behind anemia. Like at times we are confused that whether it is iron which is causing the anemia, or whether it is folic acid, or whether it is vitamin B12. So that confusion can be cleared if we have a clear virtue of these values. So how do we do that? So a simple thing is that if the hemoglobin levels are less, then surely it is anemia, right? So what do we do is the next step is to check MCV. Now, MCV is, of course, a part of RBC indices, and this is the mean corpuscular volume. So it tells about the size of the RBC cell, the volume of the RBC cell. So if the MCVs are low, along with the low hemoglobin, so we have to understand that this is an indication of iron deficiency. So whenever we encounter somebody with low iron and also with low values of MCV, then there will be iron deficiency simultaneously. If there is low levels of hemoglobin and there is high levels of MCV. So if it is just the reverse, then this time it is a condition which has arisen because of vitamin B12 and B9. There can be other reasons also like alcoholism, pregnancy, or hypothyroidism. But if none of this is there, then surely a macrocytic anemia with more MCV is because of vitamin B12 and folate. So this gives us a clear concept then in which way to move, in which way we should proceed. Now, many a times it may also happen that the anemia is directly not related to diet. Like there is no iron deficiency, there is no vitamin deficiency, but then there is anemia. So that will be considered as a normocytic anemia, where the hemoglobin is of course less, but the MCV is normal. So in this case, we look into the next value, which is reticulocyte count. It is also there in our CBC blood report. Now, reticulocytes, they are typically the precursors of RBC, the precursors of erythrocytes. And these reticulocytes can tell us that whether our bone marrow is working or not. So if we see that somebody has low hemoglobin, normal MCV, but the reticulocyte count is increased, So that is when we have to understand that this can be a case of hemolysis. Like say, for example, somebody is having hemolytic anemia. Maybe G6PD deficiency is there, right? Or maybe there's excessive blood loss. So maybe there is a condition in a community where girls at an early age, due to their periodic blood loss, are getting into anemia. So we can confirm it by these values. We can check the value of reticulocyte and we can get a confirmation. At the same point of time, if the reticulocyte values are normal, then the anemia which is appearing, it is because of any other chronic disease. Many a times CKD patients, like we know, due to the absence of erythropoietin, they lead into the situations of anemia. So in that case, the reticulocyte counts will appear as normal. Now, there is another value which is also counted in our RBC indices, and that is red cell distribution width, which is called as RDW. And this gives a clear idea that what is the width of the RBC that we are having. Now, what is the significance of this value? So say, for example, there is a case where somebody is very, very malnourished, right? And that person is having both iron deficiency and B12 deficiency. So if it is a combination case of anemia where both iron deficiency is there and B12 deficiency simultaneously there, then the RDW values will be higher. So like that, we get a characterization that in what aspect we must approach. So the main vitamins which are involved in maintaining the blood levels are, of course, vitamin B12 and folate. Now, at times, people are again confused because we don't get a clear idea that where it is particularly vitamin B12 deficiency or where it is just folate deficiency. So a way of identification can be that in both the cases, for folate and B12 deficiency, for both the cases, the MCV values are going to be high. But if it is particularly B12 deficiency, then the MCH value will also be high. Now, MCH is again a part of RBC indices, and this represents that here the B12 deficiency has arisen. Now, in order to confirm, we can surely go for serum test, right? Like serum B12 levels or serum folate testing we can do. And other than that, there is another significant tool to identify whether a person is having B12 or folate deficiency or not. And that is by measuring homocysteine. Now, homocysteine is an amino acid which was supposed to be metabolized by the body. But whenever there are deficiencies of B12 and B9, then homocysteine is not metabolized and it starts accumulating. So those who have deficiency for both these vitamins, they have high levels of homocysteine in blood. Now, this is one test which is getting very favorable nowadays. People are preferring to do this test. Why so? Because homocysteine is actually a whistleblower. Right? So if the homocysteine levels are going high, so it is not only that the anemia is happening, it is also that your heart is also getting affected day by day because of the homocysteine levels. So there will be a very high chance of atherosclerosis. So we can even screen out that even for patients who are not anemic, this test can be done. Now, many a times we always say that there should be a combination of folate and vitamin B12 because both will help in the production of blood, and that is true. But there is one thing that we must realize, that is the B12 deficiency symptoms, which we generally see, like low levels of hemoglobin, anemia. We also see there are nerval issues and this type of conditions we experience, right? So these symptoms will actually get masked if somebody is taking excess folate. So say, for example, somebody is having both B12 deficiency and folate deficiency, correct? Now, at that moment, if that person is particularly taking excess folate and moderate B12, then what will happen is the symptoms will go, the symptoms will overcome. The folate will mask the symptoms of vitamin B12, but the B12 deficiency will persist. So we have to understand that the testing is a very important fact to get a clear idea that what exactly is going on. Now, the year of 2000 was very important for understanding anemia because there was a discovery of hepcidin. Now, hepcidin is a very peculiar hormone, a hormone which regulates iron metabolism. So typically we have this concept that iron always depends on diet, but after the discovery, it's a game changer. Now we know that iron levels are actually decided by the liver. So what happens is that we all have some amount of hepcidin in our body. So hepcidin regulates the amount of iron. The hepcidin makes sure that there is no iron overload in our body. But when there is inflammation in our body, then during this inflammation, the liver is triggered and there is excess release of hepcidin. Now, hepcidin is something which stops iron absorption and even iron recycling. So somebody who is having chronic inflammation, and at the same point, if that person is also anemic, so here we have a challenge because there is severe inflammation, then there will be higher levels of hepcidin. And as a result, dietary addition of iron to that person won't help. So in order to deal with that, it is important that first the inflammation is regulated, followed by which the dietary addition of iron will be actually absorbed and utilized by the body. So in that context, the identification of the inflammatory markers becomes very important. So if there is somebody with higher levels of C-reactive protein, or you can go for a high sensitive C-reactive protein, that is again a better way of analysis. If these values are higher, then surely the person will have less iron absorption. So inflammation must be regulated at first. Now we have talked a lot about low levels of hemoglobin. Now, many a times the hemoglobin levels can be higher. Typically, when there is a chronic issue with lungs or heart, when the body fails to get the required oxygen, then the body pushes itself to produce more hemoglobin. But at times, healthy individuals can also show a partial rise in hemoglobin, maybe 15 or 16, right? So that can happen because of dehydration. So we have to understand that the measurement of hemoglobin is done on the basis of concentration. So whenever there is dehydration, automatically the hemoglobin levels, which are read in the reports, they go higher. There can be other reasons as well, like smoking and living at higher altitudes. Now, while discussing about anemia and screening of iron deficiency, the iron profile becomes very, very important because it actually tells us that whether a person is anemic or whether a person is just into iron deficiency. So let's understand that what the report has to tell. So in our iron profile, we see the serum iron levels. Now, serum iron shows the free iron, which is roaming in our blood, and it does not have a very significant impact. The next value that we see is total iron binding capacity. Now, this is a value which actually tells the greediness of our body for iron. So if somebody is having iron deficiency, so definitely the total iron binding capacity will be very high. At the same point, if somebody is having excess iron in the body, so the total iron binding capacity will be low than normal. If there is transferrin saturation, which is very common in someone taking excess iron in diet, and even if the person is not taking supplements, then excess dietary or external sources of iron can cause severe iron saturation. The serum ferritin level are also very significant because, like we know, that ferritin is a storehouse of iron that we have. So it's more like a piggy bank where our body prefers to store the iron. So whenever we suffer with iron deficiency, even at a very early stage, the first thing that tells us that here is a problem is serum ferritin. So serum ferritin level goes down at first. So what happens is that the symptoms of anemia and the symptoms of iron deficiencies are very common. They are very overlapping. So at times it becomes very challenging to identify that whether a person is just iron deficit or whether a person is anemic. So at that context, we have to realize that there are certain stages. So at stage 1, where the body is losing iron at the beginning, the ferritin levels will typically go low. And then we see if there is a persistent deficiency of iron, then the serum iron will go low. There will be an increased demand of total iron binding capacity. And if the person heads towards anemia, then of course there will be a lowering of hemoglobin along with severely high levels of TIBC. So if it is a case of iron deficiency, then we find that hemoglobin, MCV, TIBC are normal, but then ferritin levels are less. If it is a case of anemia, then we find that the hemoglobin, MCV, our serum ferritin, they all are low, but the TIBC levels, the total iron binding capacity, is extremely elevated. Now here I have a very important fact to discuss, and that is about this tribe. So this is a tribe who are called as Bantus, and they belong from Africa. And they have a very special feature. So what we generally find in them is that they have hepatic portal fibrosis, very common in them. They also show cirrhosis very significantly. Now, this tribe have some common practices also, like they cook their food in iron pots. They also prefer to brew the beer in iron vessels. So as a result, they are exposed to excessive iron. So this excessive iron, as because iron is a very heavy and a complex metal, so this excessive iron start getting deposited over their liver and create so much of physiological problems. Iron is also highly reactive. So as a result, it end up creating the free radicals, more oxidative stress. So the organ systems are getting damaged. And this is what is a sheer example of iron overloading. So why iron overloading? So typically there is a term for this which is called as hemochromatosis. So many a times what happened that there are certain issues with our gut lining for which there is excessive absorption of iron. So that can lead to iron overloading. Or it may happen that there is a secondary cause like excessive intake of dietary iron or supplementary iron. So how do we analyze that? Like say for example, there is somebody who is taking iron for long. So it may happen that the serum ferritin levels are going high. So that will be a significant identification that whether the person is heading towards iron loading or not. Even in case of iron overloading, the transferrin saturation will be very high. So whenever there is iron overload, like I said, then iron starts affecting the organ. The liver gets affected, the heart gets affected, and even the endocrine system also gets affected. Now, those who are dealing with thalassemia. So we know that thalassemia is a condition where there is frequent blood transfusion. There is a need of frequent blood transfusion. And as a result, they are more prone to iron overload. So typically, the thalassemic patients, they always must restrict or reduce their iron intake. So a dietary management is surely needed. Now, typically, we always say that phytates are to be reduced and vitamin C should be taken just to increase the levels of iron. But for them who are into these conditions of iron overload, it is important that calcium-rich food should be given, polyphenols and phytates should be taken so that the excess iron absorption can be reduced, can be controlled. Thank you so much. This is all that we had to discuss today. And if you have any question, please put that in the chat. We will be taking it by the end of the session. I request Mr. Soumyendu Ghosh to take over and continue with this session.
Ma'am, I have question.
I will take the question at the end after the vitamin D session. So it is really, thank you so much, audience, to stay with us. Please put your questions in the chat box or you can unmute at the end. It is a very crisp session, though it is a very elongated, it should be very elongated, but you have made it very crisp and especially interesting of the tribes and iron overload. So without any delay, I am coming to our next speaker and we are very much excited for the topic and the speaker both. That is Mr. Soumam Dutta from National Institute of Nutrition. So let me share the screen and just brief about Soumam. So Soumam is currently at National Institute of Nutrition, Hyderabad, where he is doing his PhD on, and his area of specialization is classical and non-classical functions of vitamin D, nutrigenomics, and on the public health. So he's UGC Senior Research Fellow and PhD scholar there. His MSc and BSc is both from Calcutta University, and he is the first rank holder in both graduation and masters. Former DST Inspire SHE scholar, Government of India, worked as a research intern in NICED. He has many publications, his own articles, journals, and he has received many awards. He is also the life member of Indian Dietetic Association, IPN is SND, that is Society of Nutrition and Dietetics, Nutrition Society of India. So with a very short introduction of Soumam, we are eagerly waiting to know many unknown facts about vitamin D. And vitamin D is nowadays very important in our clinical practices, though it is a pediatric practice for the diabetologist. In each and every prescription, psychologist, psychiatrist, each and every prescription we are finding go for serum vitamin D test. And 80 to 90% in the urban populations, we are getting deficiencies. So we are eagerly want to hear from you.
Yeah, so thank you so much, Soumyendu sir, for the wonderful introduction. I'm really delighted and honored to be here today as a speaker, and I acknowledge IAPN India and IAPN Kolkata chapter and the Community Nutrition Core Group for organizing this webinar and inviting me as a speaker. So I'll be sharing my screen. Uh,
Sure. Yes. Now you can go to the PPT. Yes, it is full. Make it full screen and go ahead.
Visible now?
Yes, perfect. You can go ahead.
Okay, so a very good evening to everyone. Today, the topic which I'm going to discuss today, as sir has already mentioned, it's a very important and interesting topic, and it's all about vitamin D, its role in metabolic health, and implications for public health. I'll be also sharing some research updates and updated guidelines, whatever we are having right now regarding vitamin D testing and supplementation. So let me begin with a basic overview of vitamin D. So more than a vitamin, it's a hormone, rather a prohormone. It's a secosteroid prohormone. Why prohormone? Because vitamin D is activated at liver and then finally at kidney by hydroxylation, leading to the formation of 125 dihydroxycholecalciferol or calcitriol, which is the active form, hormonally active form. It's produced in kidney and it exactly functions as a hormone. So in our ancestors, those who used to be in sunlight for prolonged hours, in their body there was no much need of dietary vitamin D, because they used to synthesize it and it used to function as a hormone. But with increase, changing lifestyle, urbanization and things like that, uh, vitamin D, which is basically a prohormone, is now a vitamin. That is something which we should consume through our diet. So it synthesizes from its precursor, that is 7-dehydrocholesterol, in the epidermis layer of skin upon UVB exposure. And it can also be obtained through dietary sources, although sources are limited. And the circulatory form of vitamin D is 25 hydroxy vitamin D. It's the most stable form which is tested in the serum, and it's the circulatory form. And the hormonally active form, as I mentioned, it's 125 dihydroxy vitamin D. So coming to the functions of vitamin D, we can classify the functions of vitamin D into two broad categories. One is the classical function, which involves phosphocalcemic homeostasis, and the skeletal effects of vitamin D. So vitamin D basically improves calcium absorption from the intestine, calcium reabsorption from the kidney, and bone turnover. And also it maintains the serum calcium in a normal range, that is around 9 to 10 milligrams per deciliter. And if there is a drop of this calcium level, the PTH levels goes up, and therefore we have this secondary hyperparathyroidism as a result of vitamin D deficiency. The non-classical functions include vitamin D's effect in the extraskeletal targets, which include muscle, adipose tissue, lung, immune system, prostate, heart, the central nervous system, very important, and pancreas. All these tissues express VDR, vitamin D receptor, which is basically important for vitamin D action in these target tissues. And also these tissues express 1-alpha hydroxylase enzyme, and therefore these tissues are involved in the local non-classical activation of vitamin D to 125 dihydroxycholecalciferol. There are different factors which affect serum vitamin D levels. It includes like the time of the day. So as we know that for vitamin D synthesis, we need midday sunlight because the proportion of UVB is highest during the midday. That is between 10 a.m. to 3 p.m. We do not synthesize much of vitamin D in early morning or maybe in late afternoon sunlight, because the UVB proportion will be very less. And remember one thing: if we are not developing skin tan, that means we are not synthesizing vitamin D. Season is very important. Highest vitamin D synthesis can be observed in summer and lowest in monsoon due to cloud cover, and also in winter because the sun rays are too oblique in winter. Latitude, so maximum vitamin D synthesis occurs between 35-degree north and 35-degree south. So those who are in the tropical countries, they are in a better situation, although there are numerous factors because of which, even though we Indians are and other some developing countries, although we are in a tropical region, we do not synthesize much of vitamin D. And there are factors like air pollution, very important. So the air pollutants, they absorb this UVB proportion of sunlight. Therefore, when there is lot of air pollution, especially in the urban regions, we do not synthesize because this UVB proportion is not available to us for vitamin D synthesis. Sunscreens, definitely an SPF of 50 reduces vitamin D synthesis by around 98 to 99%. And therefore, those who apply sunscreen all over their body, like hands and back and face, everywhere, they are at a higher risk of developing deficiency. On facial skin, definitely we can apply sunscreen because in facial skin we don't synthesize much of vitamin D, but definitely not on hands or back. So what we need is smart sun exposure. I'll discuss that later. And smoking also reduces vitamin D levels, and there are negative associations, inverse associations between smoking and vitamin D levels. So, I'll be discussing some vitamin D dependent biochemical and biophysical markers which can be used for vitamin D status assessment. So, the serum 25 hydroxy is the gold standard biochemical marker for vitamin D status, serum 25 hydroxy D, because it's the most stable form. Along with that, we have serum calcium. So if there is vitamin D deficiency, there will be hypocalcemia, and if there is vitamin D excess or toxicity, there will be hypercalcemia. Serum phosphorus levels, it vary. Sometimes it goes down, sometimes it goes up under deficient situations. PTH, definitely in vitamin D deficiency, PTH levels will be too high due to secondary hyperparathyroidism. Alkaline phosphatase, it releases from bone due to bone resorption under vitamin D deficient conditions. And CTX1, this is a marker of bone resorption. So if there is too much bone resorption in vitamin D deficiency, CTX levels go up. And osteocalcin is a bone formation marker which goes down under deficient conditions. So CTX, osteocalcin, although these are measured at clinical level, but mostly these are used in research studies. Another very important marker which is now being used is vitamin D metabolite ratio, VMR, which basically represents the free fraction of 24-25 dihydroxy D3 to free 25 OHD. So 24 hydroxylation leads to inactivation of vitamin D. So this vitamin D metabolite ratio ideally represents how much vitamin D is inactivated as compared to how much active vitamin D we have. And this is found to be a much better marker of vitamin D status than all these markers alone. So what should we measure? Should we measure 25 hydroxy D or 125 dihydroxy D? So 125 dihydroxy, that is calcitriol, this is the actual thing. Like this is the hormonally active form. All the actions of vitamin D are exerted by this calcitriol 125. But this is not stable. I mean, this is highly controlled under feedback regulations, and it does not reflect the amount of vitamin D that we are consuming through diet or maybe synthesizing in the skin. So what happens is PTH increases 1-alpha hydroxylase enzyme activity. So if you have vitamin D deficiency, PTH levels go up and it stimulates 1-alpha hydroxylase enzyme in the kidney and it produces more and more this active form. So even under vitamin D deficient condition, this calcitriol remains high under normal, like in humans especially. Therefore, 25 hydroxy D, 25 hydroxy D2, D3 total, these are considered to be the gold standard biomarkers for vitamin D status. And also the half-life of 25 hydroxy D is greater than 125D. So for 125D, it's around 24 hours. And for 25 hydroxy D, it's around 15 days. So definitely you can understand why 25 hydroxy D is considered to be the best marker. Now we have other biophysical parameters and some nuclear parameters. For example, body composition. It reflects our vitamin D status basically. So we have this bioelectric impedance analysis, BIA, which is basically a two-compartment body composition analysis model. Two-compartment means it measures fat mass and fat-free mass. We have DEXA, which is a three-compartment body composition analysis test. So in DEXA, we can measure fat mass, lean body mass, bone mineral content. We also have nuclear techniques like whole body potassium counting. So potassium is basically trapped within the body cell mass, within the cells. So within the lean tissue especially. So how much potassium is present, that can be calculated by using whole body potassium counting. There are separate, instruments for it, which is very expensive. Very selected institutes and hospitals in India have it. So whole body potassium counting, it's a 4-compartment body composition analysis system. And for DEXA, which is considered to be gold standard because it's widely available, almost every clinic has it now. And BIA, although it is more, cheaper than DEXA and portable, it's not a gold standard one. DEXA is the best measure. Whole body potassium count, definitely you can go for it, but it's again very expensive. So for DEXA, we have this T scores. T scores basically represent the bone density, mineral density of the subject as compared to the young, healthy population average that we have. So it compares your bone mineral density to a reference young, healthy subject. So, based on this T score of DEXA, we can understand whether there is osteoporosis or osteopenia or normal BND, which ultimately reflects your vitamin D status. We also have stable isotopes. Now, the problem with DEXA is that it cannot. It takes huge time to see small changes in bone mineral density. So, suppose if you are taking vitamin D supplements, won't readily change your bone mineral density. So therefore, we feel like, okay, even though we are taking supplements, there is no improvement in bone mineral density. Why? Confused. But this is not the ideal way to check. DEXA is not the ideal way to check the effects of short-term vitamin D supplementation. So for understanding the effect of short-term supplementation of vitamin D, we have stable isotopic techniques. So in our body, naturally, we have calcium 40 isotope. We also have calcium 44 isotope. So when there is bone formation, calcium 40 is deposited in bone and calcium 44 isotope is excreted in the urine. So, upon vitamin, this is a study which was conducted at the St. John's Research Institute, Bangalore. So, what they did, they took vitamin D deficient subjects, they recruited them, one group received 60K IU vitamin D3 for 3 weeks, and they had a control group. So they observed that in urine, the ratio of calcium 44 to 40 increased. That means more calcium 40 got deposited in the bones and 44 was excreted through urine, which indicates there was a positive bone mineral balance. So if you want to see the effect of short-term vitamin D supplementation, you should always go for such stable isotopic techniques. For that, you should have a mass spectrometer with you. It's
Can you
definitely
please mute?
doable. Lot of noise.
Yeah, there's a lot of noise. Can the people mute?
Okay, so now I'm coming to the epidemiology of vitamin D deficiency. As you know, it's a global burden, public health burden, and almost 16%, 48%, and 77% of individuals worldwide are found to have severe, moderate, and mild deficiencies of vitamin D. So, vitamin D deficiency or insufficiency. And in India, the prevalence is more than 70%. We do not have any national level data for vitamin D deficiency right now. We do have CNNS data, but that's only for children and adolescents, but not anything as of now for nationally representative adults. Probably when the DABS results come out from NIN, we have a better picture of vitamin D deficiency scenario in India. So, who are at risk of vitamin D deficiency? Those who have very less sun exposure, basically. Those who are working in night shifts, those who are homebound, then hospitalized patients, critically ill patients, they are at very high risk of vitamin D deficiency. Elderly individuals, they have a reduction in their skin cholesterol levels, skin 7 dehydrocholesterol levels especially. They also cannot synthesize much of vitamin D. Obese people, in obesity, in the adipose tissue, vitamin D gets trapped, so the serum levels go down. Pregnant women are at risk of developing deficiency. Malnourished children, like those who are having SAM, these children are prone to develop deficiency. Also, those who have hepatic and renal insufficiency, they can also develop insufficiency. Why? Because uh, the activation of vitamin D occurs in liver and kidney. Also, there are certain drug nutrient interactions. Certain drugs are there which interfere with vitamin D metabolism and increases its catabolism. For example, some anticonvulsant medications like phenytoin, some anti-tuberculosis medications like rifampicin and isoniazid. Those medications interfere with vitamin D and leads to its catabolism. Now, I'll shortly highlight the burden of NCDs that we have, because today I'm going to connect vitamin D with NCDs and metabolic disorders, because the classical functions are very well known and we all study about it very frequently. But I'll be highlighting this non-classical effects. So, non-communicable diseases, especially the diet-related non-communicable diseases, NRCDs, are increasing in India, even though there are a lot of policies and interventions being planned. So there are so many behavioral factors, lifestyle factors, dietary factors, and nutritional inadequacies definitely contribute to this NCD burden. And there are so many metabolic factors like overweight, obesity, raised blood pressure, raised blood sugar, dyslipidemia, which ultimately contribute to NCDs like CVDs, then respiratory disorders, COPD, asthma, diabetes, and so on. So let's look at how vitamin D is involved in these different, disease outcomes and metabolic health. So, inverse associations are observed between serum 25 hydroxy D levels and waist circumference, blood pressure, fasting blood glucose, metabolic syndrome in epidemiological studies. Also, vitamin D is found to improve lipid profile and it exerts anti-inflammatory effects. So basically, it promotes a shift of Th1 helper T cells 1 to helper T cells 2 and macrophage 1 to macrophage 2, M1 to M2, profile shifting. So this Th1, M1, these cells of immune system, they are pro-inflammatory, whereas Th2, M2, these are anti-inflammatory. So vitamin D promotes this profile shifting of Th1 to Th2 and M1 to M2, which ultimately exerts anti-inflammatory effects. So it's very important. Vitamin D is very important to maintain our metabolic health, and it is positively associated. Deficiency of vitamin D is positively associated with metabolic syndrome. So regarding CVDs, this is one of our latest publications where we have highlighted the different mechanisms which are involved in the modulatory role of vitamin D in CVD. So basically, vitamin D has numerous functions in the cardiovascular system. It exerts antihypertensive function, antifibrotic, anti-inflammatory, antioxidant, anti-apoptotic functions. It improves left ventricular function, thereby helps in pumping of the heart. It improves endothelial function and it also increases myocardial cell differentiation. There are numerous cell signaling pathways which are affected by vitamin D. In fact, in development animal models, vitamin D is found to be associated with cardiac atrophy. It basically reduces the protein synthetic pathways like mTOR pathways and increases the protein catabolic pathways like this ubiquitin proteasome pathways. And also in human studies, it is observed that vitamin D deficiency is associated with left ventricular hypertrophy. So what happens is that vitamin D helps to maintain a proper balance of protein synthesis and degradation in cardiac tissue. If there is deficiency, prolonged deficiency, chronic deficiency since childhood, there are chances of developing cardiac atrophy. Whereas in adulthood, if there is vitamin D deficiency, there are chances of developing cardiac hypertrophy. Diabetes, definitely, it's very well studied the role of the involvement of vitamin D in diabetes, both in type 1 diabetes, type 2 diabetes. Vitamin D increases insulin secretion because calcium is involved in insulin release. Calcium signaling is required for insulin release from the pancreatic beta cells, and if there is a deficiency of vitamin D, this calcium homeostasis gets impaired and therefore insulin secretion, insulin turnover gets impaired. Also, it improves insulin responsiveness in extrapancreatic tissue by upregulating the insulin receptor gene expression. It has inverse association with HbA1c, glycated hemoglobin. Also, vitamin D has very important role in muscle health. It maintains muscle mass and muscle atrophy, reduce grip strength, which these are commonly observed in diabetes patients, and vitamin D has a very good role to play. It vitamin D deficiency increases 2 times almost. It increases the risk of developing diabetic foot ulcers, and also in medium patients, gestational diabetes mellitus patients. Vitamin D supplementation is found to reduce the adverse neonatal outcomes. Vitamin D, it's associated with cancer. It basically reduces cell proliferation and increases cell differentiation, and also it has anti-neoplastic effect. I'm not going into the details because it will be too prolonged, then I have to be on time. And low circulating vitamin D levels are associated with increased risk of many cancers. I'll show a few more specific ones in later slides. Respiratory disorders, definitely. Vitamin D is involved in chronic rhinitis, certain viral respiratory infections, COPD, asthma, because it modulates the immune cells of the lung. Okay, so it modulates the profiles of the immune cells which are present in lung, and it shifts them towards a anti-inflammatory phenotype. Anemia, we have discussed a lot today about anemia. Vitamin D deficiency is linked to anemia. How? Not directly, like nutritional anemia, what we have. We are mostly concerned about iron, folic acid, B12. But due to inflammation also, there can be anemia. Okay, so in chronic inflammation, in non-communicable diseases, there are the hepcidin level, which we discussed just now. Hepcidin levels go up, and they trap this sequester. They have iron sequestering effect. So it traps iron, and therefore iron becomes unavailable for hemoglobin synthesis. So due to chronic inflammation, there will be anemia. And vitamin D exerts anti-inflammatory effect. It suppresses hepcidin expression. It promotes erythropoiesis, mostly through its anti-inflammatory effects by reducing the levels of pro-inflammatory cytokines and increasing the levels of anti-inflammatory cytokine. It ultimately reduces hepcidin, which makes iron available for erythropoiesis. And therefore, we should remember that the 666 strategy that we have in Anemia Mukt Bharat, out of the 6 intervention, the 6th one is to tackle the non-nutritional causes of anemia. And that includes this inflammatory conditions and some other conditions like hemoglobinopathies and then malaria. And these results will vary based on whether we are taking finger prick detection of hemoglobin or venous samples. So venous blood samples is the ideal one for hemoglobin estimation. If we measure hemoglobin finger pricks, it doesn't show the exact value. It may show very high or very low value. So venous blood samples are always the ideal one for anemia assessment. Vitamin D is associated with stunting, so higher vitamin D supplementation is basically found to improve the height for age or length for age scores. So it has very important data. Its stunting is a huge problem in India, almost 35% prevalence. So definitely, therefore, even IAP advises vitamin D supplementation in infants, and also for pregnant women, it is advised to supplement vitamin D. Infectious diseases, definitely vitamin D is involved, has beneficial roles in tuberculosis, influenza, upper respiratory tract viral infections, and especially COVID-19. It was observed that those who receive vitamin D supplements, they had very less chance of developing COVID-19 and ICU admissions. So fatality was very low in vitamin D supplemented individuals. Also, this GBS outbreak that we have currently in India, that is also like vitamin D has very important, very positive role in all these multiple sclerosis, lateral sclerosis, and then autoimmune diseases that we are having, including this GBS outbreak right now that we are having in India. Vitamin D improves gut microbiome. It promotes the gut barrier integrity, the tight junction, gap junction proteins which are there, which helps to maintain the gut mucosal lining. Vitamin D helps to maintain that lining, and this is important to prevent malabsorption of all nutrients and to maintain a gut eubiosis. So it basically improves the predominance of beneficial microbes like bifidobacterium, Akkermansia, and it also increases the expression of antimicrobial proteins like cathelicidin. And overall, it reduces GI inflammation. So in gastrointestinal inflammatory conditions also, vitamin D has a good role to play. Vaccine efficacy, it's very important thing now. Vitamin D is found to improve influenza, hepatitis B, tetanus vaccine responses. Although the studies are mixed based on the host factors, vaccine related factors, but it's very commonly observed that elderly, obese patient subjects and subjects having chronic kidney diseases, liver diseases, they have a very high chance of vaccine failure, which is in turn associated with their vitamin D levels. In our latest review article, we have focused on the connection of diet, microbiome, probiotics in vaccine efficacy, where we have highlighted the role of vitamin D in maintaining gut eubiosis, which ultimately improves vaccine efficacy, because gut microbiome eubiosis is very important to optimize the immune response towards different vaccines, and vitamin D helps to maintain this link between microbiome and vaccine efficacy. However, the clinical studies which are done using vitamin D, they have mixed outcomes. Some studies have shown very positive outcomes, where some have shown null effects of vitamin D, especially in cardiovascular diseases and so on. We get so many studies which have shown null effect of vitamin D supplement on different disease outcomes. Why? Because there are multiple confounding factors that we get, especially when we deal with nutrients. Because there is the effect of vitamin D supplementation, maximum effects are observed in vitamin D deficient individuals. However, when these clinical studies were being conducted, like this vital study and so on, those were conducted on vitamin D repleted individuals. They were already having good levels of vitamin D in their circulation. So they added extra vitamin D, there was no much effect. Also, these disease outcomes, chronic disease outcomes like CVD, cancer, these take very long time to develop. And therefore, the studies which mostly check the effects of supplementation over 3 months or 6 months, they do not show much effects during this short time span. And another big factor for vitamin D especially is that the control group, they always get exposed to some amount of vitamin D through sun exposure or maybe through dietary sources, fortified food sources. So therefore we cannot exactly compare the intervention group with the control group, because the control group is also receiving vitamin D. At least the RDA levels need to be maintained. Otherwise, those kind of studies will not get ethical approval. So now vitamin D has a U-shaped relation. So beyond, there is an inflection, up to 400, 600 IU per day of vitamin D supplementation. All these parameters improve. But after that, there is a plateauing. So it's like a non-monotonic relationship. If you increase vitamin D intake from 0 IU to 400 IU, all things will improve. But after 400 IU, it will start plateauing. So therefore, higher dosages like 2000 IU per day, 4000 IU per day, they do not show much extra additional effects beyond the RDA levels, that is 600 IU per day. However, these relationships, like relationship of vitamin D with many cardiovascular diseases, diabetes, cancers, many of these are just observational studies, epidemiological observations, which may or may not be causal. So to understand the causal relationship of vitamin D with disease outcomes, we need Mendelian randomization trials. So in Mendelian randomization trials, what we see is that those who are genetically prone to develop vitamin D deficiency, do they have higher chances of getting certain diseases? Then we can understand that yes, there is a causal relationship. So causal relationship has been observed between vitamin D and following conditions like multiple sclerosis, which is an autoimmune condition. Very definitely vitamin D has a direct involvement in multiple sclerosis, autoimmune neurological disorder, non-infectious uveitis, scleritis, psoriasis. We all know vitamin D works like magic in psoriasis, femur fracture, leg fracture, amyotrophic lateral sclerosis, anorexia nervosa, which is a eating disorder, psychological eating disorder, delirium, heart failure, ovarian cancer in particular, non-alcoholic fatty liver disease, dyslipidemia, and bacterial pneumonia. So we have found causal relationships between vitamin D and these following conditions. So therefore, these patients are at risk of vitamin D deficiency and they should be screened properly. Now, sunlight or supplement, both can work, but with supplements, we have better, compliance, unlike sunlight. So both are effective. Both are not equally effective because sunlight, again, so many things will matter like air pollution, UV index, skin pigmentation. Definitely, supplement is more effective, and but it's not much cost effective, but sunlight is cost effective. So we have pros and cons for both, but the major issue is compliance issue with sunlight, which we don't have much with supplements. D2 or D3, this is a very commonly asked question. Now, if you look at the public health policies that we have right now in India, they all fortify food items with vitamin D2. However, D2 is not as effective as D3 because of the structural differences. D2 is a less preferred substrate for the different enzymes that we have in the vitamin D metabolism pathway. And vitamin D3 has 2 to 3 times greater effect in increasing the serum vitamin D level. So D3 should be the preferred choice, but due to this vegetarian, non-vegetarian sources, most of these public health programs in India, they are considering D2. Although from our side in NIN, we are trying to push the ministry for D3 fortification. Routine testing, I'll be closing within just 1 or 2 minutes. Routine testing of vitamin D is not recommended right now by the Endocrine Society because there is no much benefit of vitamin D testing. It's too much costly. Without testing also, we can go for supplementation, which is known as empiric vitamin D supplementation. Testing can be performed only under certain clinical conditions where there is a specific need for testing. So the thing is, for adults, there is no need of vitamin D supplements for those who are between 19 to 49 and 50 to 74 years of age. Until and unless there is any specific clinical need, there is no recommendation for vitamin D supplementation. But for ages 1 to 18, for elderly individuals above 75 years, in pregnancy, in pre-diabetes, we can go for empiric vitamin D supplementation. That means supplementation without testing. So testing is not at all recommended right now because without testing also we can recommend vitamin D supplements empirically based on the data and evidence that we have. Although in certain clinical conditions, we need to measure vitamin D levels, like those who are taking certain medications which reduce vitamin D levels, and those who are having nephrotic syndrome because they lose lot of proteins and with that they lose vitamin D. So the consensus statement is that we should prefer oral vitamin D3 supplementation. Orally, vitamin D should be supplied either through diet or through supplements. Those who have malabsorption, those who cannot absorb vitamin D, for them parenteral injections can be given, vitamin D injections. And those who have some defects in their metabolic enzymes in 25-hydroxylase, 1-alpha hydroxylase, for them 25-hydroxy D or 125-dihydroxy D supplements can be given, either orally or parenterally. So this is the consensus statement latest that we have from the international bodies. And also there are some non-calcemic analogs because with vitamin D, many people are worried about toxicity and hypercalcemia. So we have non-calcemic analogs which are very safe, like pericalcitol and doxycalciferol. If you supplement with these analogs, it won't lead to hypercalcemia or the classical toxicity. Fortification, this is my last slide. Fortification, it's now from FSSAI, it's being recommended that milk and edible oil should be fortified with vitamin D. Different levels are mentioned. So if you take fortified milk, fortified edible oil, you can meet your daily requirements, which is good enough. And also, Another thing we should remember is that the daily dosage of vitamin D is better than the bolus intermittent dosages. But again, with daily dosages, we have compliance issues. So you can recommend bolus dose, intermittent dose, but definitely daily dosages are found to be more effective. So to sum up, we can understand that it's very vitamin D is very important for its non-classical and classical effects. However, routine testing of vitamin D is not required. It's very expensive and doesn't help in additional clinical decision making. RDA levels is maintained for everyone, and those who are at risk of developing deficiency, for them we can go for empiric vitamin D supplementation. Empiric means without testing. And for dosages, we should remember one thing, that the tolerable upper intake level is 4,000 IU per day. So whatever dosage you are recommending, it should not cross 4,000 IU per day. We should promote outdoor physical activities through public health programs. And for clinical decisions regarding testing and supplementation, that will vary from case to case. So if there is any clinical need, definitely we can get tested and take supplements accordingly. So thank you so much for this opportunity. I'll be happy to take questions. This is all from my side.
Thank you so much, Soumam and Vijaya. So it is really a nice presentation for the clinical practitioner. I request everybody, please keep on mute for some time so that somebody is on unmute. Yes. So I will take the questions from the chat box. Soumam, by that time you can see the chat box. One question I want to ask you, Soumam. What about vitamin D toxicity? You can stop sharing the screen. So what
I have
about?
already stopped sharing, so I guess.
No, it is already shared. So
Okay.
So,
Yes.
so I request the audience, you can switch on the video. We'll take the questions from the audience. And I really want to thank our Kolkata chapter vice president, Sudeshna ma'am is also there. Deblina Dotto, treasurer, she is also there with us. So thank you for joining in their busy schedule from the office and the hospitals and in the weekdays. So, Shomam, what about the hypervitaminosis? You are stating about the daily doses. Also, some people are not aware about the fact of taking
Yes.
vitamin D and also not guided by the physicians. So, what can be the detrimental effect if there is vitamin D toxicity, which is above 100 ng per ml?
Yes. So basically, with vitamin D toxicity, the classical problem that we have is calcification of soft tissues. There will be hypercalcemia, and soft tissues will be calcified, which is definitely serious condition. So therefore, we should not cross the tolerable upper intake level of vitamin D that is recommended by ICMR NIN. It's 4,000 IU per day. Even if we are giving a bolus dose or intermittent or daily dose, whatever it is, we should not cross that level, because above that there will be toxicity. There can be toxicity, although there is a safe limit beyond that UL, but we should not cross. And definitely, toxicity is not that major public health issue right now.
Okay.
Deficiency is. So we should be more worried about the deficiency thing, but definitely clinically we have to consider this as well. And therefore we have this analogs, non-calcemic analogs of vitamin D that I just discussed. So the doctors, the professionals can decide that which which analog they want to prescribe.
Okay. Thank you so much. Vijaya, one question is there. If we are taking the iron supplement for a long time, prolonged time, so there is a chance of constipations. So how will you address this question?
Yes, like we have seen in the slides itself that iron is very slow mobilizing element. So whenever we take iron supplements, there's a high chance that the most of the amount will not get absorbed and it has to be excreted. So the excretion needs time. So what happens is that the iron actually starts accumulating in the intestine. And as a result, it requires more and more water to dilute itself. So we have to increase the water intake if somebody is on iron supplement. The next thing is iron supplement comes in multiple variants, like there is ferrous sulfate, which is available. There is ferrous pyrosulfate, ferrous glyconate, which is available. And again, there are certain liquid supplements also, which have their own benefits. Like we know that there are some supplements which are easy to take. So liquid supplements are also favorable, but liquid supplements mostly have ferric in them. They don't have ferrous. Even if the composition is ferrous, there will be oxidation due to open exposure and will turn into ferric. So the more ferric supplements we have, there is less absorption, of course, and more chances of constipation. So if we are selecting the supplement, we have to select it correctly. And of course, hydration is needed.
All supplement do not have the problem of constipation. The selection of the supplement is very important. Another question, I think it is both for Soumam and Vijaya. Chandrani Maiti has asked how vitamin B12 deficiency, iron deficiency, and D deficiency. Is there any relation between that? And another question for Soumam is, you have discussed about the gut, I think, gut condition and vitamin D deficiency. And what is the relation about this gut and vitamin D? So, Shomam, you can take the question.
Okay, so regarding iron and vitamin D, I have mentioned how
You
they
have
are
also mentioned in one slide.
hepcidin and inflammation. And another thing is this multiple micronutrient deficiency, what we call. It's very common nowadays. It may or may not be causally interrelated, but it's widely prevalent. That's why we also have this multiple micronutrient supplements, MMS, from WHO, which are being recommended. So definitely there are associations, but it may or may not be direct. Many individuals with anemia may not have vitamin D deficiency, but again, these conditions may coexist. And regarding gut, gut inflammation, gut dysbiosis, these are associated with malabsorption. And therefore, the absorption of any nutrient may go down in such conditions. And vitamin D helps to maintain the gut barrier integrity by improving the expression of the tight junction, gap junction proteins and
Yes.
maintaining the intestinal lining. And therefore, it promotes both gastrointestinal health and gut eubiosis, balance of this beneficial microbes to pathogenic microbes. And therefore, it has, because gut crosstalks with all other organs almost. So that effect will be there.
Okay. So another question is there by Ankita Sadhukan, and it is already I have discussed, Ankita, about the mental health, depression, cognitive development. Yes, it is very much related. Iron deficiency anemia or whatever anemia is very much dependent with the cognitive development. As in the government policies, you have seen that the cognitive health is very much related. Even the depression and mental health are very much related with both vitamin D deficiency and iron deficiency. Show me an interesting question from Miss Nandini. Nidhi or someone. How would your potassium counting is considered as vitamin D dependent nuclear parameter?
Well,
How
potassium.
whole body potassium counting is considered as vitamin D dependent nuclear parameter?
Yes, actually, whole body potassium counting is used for body composition analysis, four compartment body composition analysis, which ultimately reflects our bone mass, fat free mass, which are dependent on our vitamin D status, especially bone mass and muscle mass. So it will reflect our musculoskeletal health, and it's the best way to determine body composition, unlike BIA that we have.
Okay. So I think you got your
I
answer.
guess.
Same question, same person has asked question to Vijaya ma'am. Some people have normal hemoglobin, but elevated MCV and MCH level. What does that mean, ma'am?
I have already answered that question in the chat. I have
Okay.
discussed that it is an early phase of vitamin B12 deficiency. We have another question here from Jyoti, I guess.
Yes.
And her question is that, is iron overload connected to histamine production? And it's a
Yes.
very relevant question. I would really like to take this.
Please
Because,
take.
yes, because what happens is that histamine receptors are there in our stomach gut. So whenever there's a histamine surge, there is excess acidic secretion, more acids, then of course the iron overloading can happen. So they are surely related.
Okay. Dr. Shivangi has asked, please elaborate in terms of dietary aspects of how to ensure children, adolescent girls and women are free from anemia. Can you get this question, Vijay?
Yes. So, like we know that we do have a recommended guideline, and for every age group is different. So, we must surely follow that. We must understand that the dietary absorption is not a sole property. So, if there is iron which is getting absorbed, then of course vitamin C is needed, like we are aware. The anti-nutrients, the fighters should be surely restricted. And along with that, the other nutrient should be given great importance. Like we have seen that vitamin B12 and folate, they are many a times reduced in the body severely. So combination of will ensure that we can inhibit or we can stop the anemia in the community.
There are two questions. I may take the questions on renal. So for the CKD patients, one question is from Swati Patel. How does you raise iron for renal patients through the garden cress seeds? Is it helpful? So if you add any kinds of seeds or nuts, it is not recommended during the CKD, and especially garden cress. It is having high amount of potassium, more than 1100 mg per 100 gram potassium, and it is having 20-24 gram of protein in 100 gram. So if you are giving 10 gram, 15 gram to raise the blood, you correct the anemia, that also is very dangerous because the potassium level is high. Phosphorus is more than 600. If you check, magnesium is also high. So do not try any herbs during CKD treatment for the renal patients. And how to raise that is blood hemoglobin level. So as you know, anemia is very common in CKD patients because it damages the kidney and to produce the erythropoietin, EPO. So which is a very crucial hormone for the red blood cell productions. So doctor will prescribe medicines, or if it is required, erythropoietin injections are being prescribed by the doctor who are suffering from CKD. But as a dietitian part, we will not experiment with any types of herbs during our CKD treatment. Soumam, a question is there: when vitamin D injection is required, how low the vitamin D will go so that the injections are being prescribed?
Yes, so I just mentioned, so as per the latest guidelines, injection should be given only when there is any impairment of intestinal absorption of vitamin D. Many people have this fat malabsorption, so they cannot absorb vitamin D. For them, definitely oral supplementation will not work. In such cases where oral supplementation cannot work, then only we should go for parenteral therapy.
But
It's the
sometimes,
basic.
Shomam, we have seen our doctors that when the vitamin D is going below 6, below
Yes,
7,
under very severe conditions,
severe, then
clinically
also
we can.
they
Yes.
are giving injections.
So in this vitamin D field, there are two sets of guidelines. One is for the public health, one is for the clinical. So the public health guidelines are like this: we should prefer oral routes, but clinically, what we can do anything based on the patient, based on the case. Yes, this Uprise D3 injection is very common. I guess that is the brand name.
Very common, very common.
Yes,
60K
those who have
IU,
severe deficiency, for them it is recommended parenteral injections.
even 60K IU is prescribed for 8 weeks. And after that, once in a month, it should be continued
Yes.
for years. And no vitamin D test is required. Doctor even are saying that repeated testing of vitamin D is not at all required, what Shomam has said. So before we wind up, anyone wants to unmute and ask any question to our speakers?
Yes, for the vitamin D supplementation,
Yes,
I am
ma'am.
Sumeda. For about the vitamin D supplementation, sometimes the doctors recommend 60,000 IU. What is
Yes.
Mr. Shom's take on that?
60,000 IU, that is recommended for a week, or for intermittent dosing or like bolus dosing. It's not recommended per day basis.
What
So
is the per day
60,000
doses
IU.
you have already mentioned? Shomam, can you please mention it for ma'am again, Shumedha ma'am?
Yes, so the diet RDA is 600 IU. Tolerable upper limit is 4,000 IU per day. These are per day. Now, for supplementation purpose, we have a loading phase and a maintenance phase. So in the loading phase, 60,000 IU per week is recommended for just for 8 weeks around. After that, they are placed on a maintenance dose, which is 60,000 IU per month. So 60,000 IU per month means 2,000 IU per day, which is within the safe limit of 4,000 IU.
Okay.
Another
So,
question, what do
yes,
you think about vitamin D3 with K2?
Yes, so
yes,
it is so the mechanistically what they say is that vitamin K helps in calcium deposition in bones. So when we take vitamin K along with vitamin D, the chances of soft tissue calcification reduces because calcium is channelized towards bone formation. So therefore, many people prefer vitamin K supplementation along with D supplements.
Thank you.
It's
thank you.
perfect. There is no harm in it.
So
Yes.
So
before
I
you,
have one question.
yeah, please.
Vitamin D, I recommend 60K for 2 months and then follow-up dose of 2K, which is to be taken daily for 3 months. If the vitamin D level is, if it is 18 or 15 for elders. But what about kids? Because I have many sports nutrition children and most of
Yes.
them have low vitamin D levels. So what is the dose that is recommended for children? I want to know.
Ma'am, actually, the national and international bodies that we are having right now, they are not endorsing any cutoff for vitamin D sufficiency deficiency. Similarly, they are not recommending any particular dosages. We have the
Okay.
RDA, we have the TUL. Now it's up to you how you deal with your clients.
Mostly, I have seen according to the body weight, the pediatrician decide. So even I do not take this responsibility. Whenever there I find deficiency, I call my doctors and asking about the body weight of the patients and then asking for the pediatric dosage. So, but
Okay, sir.
pediatric age group, it is very, very common. So
Among
I,
infants, 400 IU is recommended, which is again their RDA. And
infant, yes,
whatever
So
RDA
come
chart
again.
we
What did
have,
you
we
say?
will follow.
400?
Yes.
What is the dose you said?
We have this, if you refer to the ICMR RDA 2020,
Okay, okay, okay.
get all these details 600,
Okay.
400, which age group, and what is the upper limit, everything.
So
just
I have a question. There is also a injection available which is 6 lakhs IUs, and I have seen many of the orthopedic giving it as if
yes.
it covers for the whole year. So will you recommend that?
It's okay. Actually, the best thing is daily dosing
Okay,
for apparently healthy individuals. All
okay,
these
okay,
recommendations are given for healthy individuals, those who do not have any clinical deficiency or any special clinical need. Under clinical conditions, such things can be done under supervision
all
because in
right.
public place, we can go and supervise people, right? So we have to very mindfully give the guidelines.
But if,
So
as a dietitian, when we have our patients, and if the patient comes with a deficiency of vitamin D, then the 60K IU per week is
Yes,
better, right?
is
we should
better.
recommend that. We should stick to that.
We
Such
Yeah.
should do.
parenteral dosages and all should be decided by the doctor.
Yes. Okay. And another thing, I just missed out on the reason of why vitamin K along with vitamin D. So could you please repeat that?
So the actually mechanistically, the thing is vitamin K, vitamin D supplements. If you take, it will increase your calcium absorption, and vitamin K shifts this calcium towards bone formation,
Okay.
not towards soft tissue calcification.
Okay.
So
Thank you
that's
so
why
much.
many people prefer vitamin K supplement along with D. But there is no international recommendation or national recommendation that you have to take K with D. Not,
No,
no
but
specific recommendation is
I think it would be good to take it with vitamin K because I come across many perimenopausal and menopausal females
True.
who are basically apprehensive about taking calciums daily because they feel कि if we are taking too much calcium on a regular basis, then it would probably go and make plaque. So I think then
yes.
in that case,
Yes, there is
vitamin K
no
is
harm in it. Those who prefer may go for it.
Even
Actually,
the pediatricians are preferring even some guideline, that is pediatric guidelines are coming. Arginine, vitamin K along with vitamin D supplementations for the growth stunted or the growth retardations for the children. So that is also very good, that even many nutritional or health supplements are now fortified with arginine and vitamin K in the optimal dose for the that is growth.
So then what is the role of arginine here, sir, for growth?
For the growth, they are giving for the growth. Even I do not have so much clear idea, ma'am, but I find a journal.
So that's for children.
Yes, for children in the growing phase.
Growing children, yeah.
Growing
I just
children.
want to add one point here.
Yeah,
Arginine
ma'am.
basically helps in lengthening of the bone. So that is the
Lengthening.
reason why mostly it is preferred in the growth phase by the pediatrics particularly.
That makes sense. Thank you so much.
thank you
Okay.
so much. Also,
Thank you.
the other thing, as per functional nutritionists, also some of them are recommending vitamin D3 with K2.
Yes, ma'am. I agree 100%. Can we all please switch on our cameras? Those who have already switched on, I really thank them so that we can take a screenshots for our IAPN websites and pages. Thank you. Thank you everyone
My
for
video
joining.
is unable. I can't start.
Okay. So we have international delegates also. So Sydney, you follow my page. You have also joined. Really thanks to you.
Sir,
So,
I have a question.
yeah. This
Sir,
will be the
how
last question.
vitamin D deficiency is related to autoimmune disorder?
Yeah. Soumam, take it as a last question. Autoimmune disorder and vitamin D3 deficiency, vitamin D deficiency.
So in autoimmune diseases, what happens that our own immune system attacks our own cells. So they can't differentiate between self and non-self. And vitamin D is directly involved in the functioning of these immune cells. It modulates the activity of innate immune cells as well as the adaptive immune cells that we have. So by modulating their profiles that I was discussing, like from TH1 to TH2, M1 to M2, these profiles are shifted towards an anti-inflammatory profile and hyper-responsive profile. Hyper responsiveness is the problem. Like when we say high immunity boosting food, these are not so scientific term. Immunity will be boosted by antigens, pathogens under normal situation. If you are taking food and unnecessarily there is immune activation, that is not the ideal situation. So vitamin D helps to keep your immune system in a hyper responsive state. So it will prevent unnecessary immune activation, and in turn it will protect against all these autoimmune diseases that we are having. It particularly involves the T regulatory cells, which helps to maintain this hyper-responsive state. And vitamin D modulates these immune cells. That is the idea behind it.
Mr. Soumam and Ms. Vijaya, if you can share your mail ID in the chat box so that
Yes,
we can
sure.
build these connections of our academic or interactive sessions. And it is really a nice audience. Many senior peoples have also joined today's session, and it is a very important session as well. So I really thanks all the delegates. I really thank our both the speakers, Ms. Vijaya and Soumam. And I would like to request, if it is possible, Sudeshna ma'am, if you are there, if it is possible to say one line about the session, if it is possible for you.
Can we have the recording of the session?
Yes, we'll have the recording of the session. I think recording will be given to the IAPN Kolkata chapter in their YouTube. So I will request to post this recording in all the LM groups, live member groups. If you are in the live member groups, so you can, otherwise,
Yes,
otherwise the speakers profiles are given, email IDs are given. So I will provide the recording to the speakers also. So if you get any mail from any delegates, I will request them to forward the recording. So it will be uploaded post Sunday. So I will try to give the recording as well. Okay. Thank you. Thanks a lot to all the delegates, and a very good night to everyone.
Good night. Thank you so much.
Thank you, everyone.
Good night.
Thank you.
Good night, sir. Thank you.
Thank you. Good night.
Thank you.